On chest X-ray, RVH, what do you see? Think of tough. Think of tough. Good shape kind of because of apex is lifted. When you have good shape, what it means basically right ventricular hypertrophy. When you right ventricular hypertrophy, because your RV is anterior, the one you see is mostly right. Mostly the one you see on the chest X-ray, mostly is portion of it is right ventricle. So what right ventricle is become hypertrophy, very severe, it can form the apex lah. So the apex can lift it up because of the RVH. So that's why you get the good shape.
So the RV looks like the
No. When RV become hypertrophy, it lift up your apex. So can you see the good shape because of it lah. Most of the chest X-ray, even certain chest X-ray, even in babies also, really like good shape. But in the end, you have to see where's the apex. If the apex still at the diaphragm, still at the base, it's not good shape. The true boot shape one, even though some actually looks like a boot, but we don't really call boot shape. The most important criteria boot shape is your apex, the point of the heart. If the end of the heart tu, if it's either at the diaphragm or lift up. If lift up, definitely it's good shape lah, because of RVH. So you have to correlate clinically lah what patient have. If patient don't have something like causing RVH, why patient have RVH, why patient have end up having good shape lah. If patient with TOF, severe PS, they will have good shape because of right ventricular hypertrophy. Okay, so in PS, what syndrome are related to pulmonary stenosis? A bit difficult question lah. Okay, so there are certain syndrome that will have certain cardiac defect. The easiest one, Down syndrome? No, AVSD. 50% of Down syndrome will have cardiac defect, and out of that 50%, 50% will have severe cardiac defect lah in Down syndrome. But the most common cardiac defect in Down syndrome is AVSD. So if patient diagnosed with AVSD, sometimes you have to look about it. Is patient Down syndrome or not? Because with normal children with AVSD is quite rare. Okay, that's Down syndrome lah. Turner syndrome, what cardiac defect? Don't know. Turner is coarctation of aorta or anything left ventricular outflow tract lah. Could be bicuspid aortic valve or aortic stenosis. So all the left vessel punya obstruction. That's Turner lah. Okay. So the one I asked just now, pulmonary stenosis. So right sided pula. The male Turner is what? Tak pernah dengar also. Male Turner syndrome. Noonan syndrome is also called male Turner lah, sebab most of the can happen in girls also, but mostly they are guys, they are boys, they are short as well, they have webbed neck, they have intellectual disabilities lah, but Turner don't have intellectual disabilities. Okay, but why I say male Turner? Because they are short, they got webbed neck. Okay, they have down slanting eyes, they have kind of like that's the certain features lah common in Noonan lah. So Noonan will have left-sided punya outflow obstruction lah, which is your PS, infundibulous stenosis. But on top of it, Noonan also can have atrial septal defect and also Hawthorne, hypertrophic obstructive cardiomyopathy lah. Okay, that's Noonan. DeGeorge syndrome, what cardiac defect? DeGeorge is conotruncal, means anything central lah. It can vary from your interrupted aortic arch, coarctation aorta, can be your TOF, tetralogy of failure lah. So DeGeorge, conotruncal defect. Okay. Williams syndrome. Williams syndrome will have aortic stenosis lah. If patient is born with aortic stenosis, You have to think, this child Williams or not. Sometimes we just send the karyotyping and straight away look for Williams punya problem lah, genetic punya defect. Okay, just purely autistinosis, tak ada apa-apa. It can be supravalvular, it can be at the valve level lah. I think that 5, 6 probably, probably that's the example lah of the syndrome with cardiac defect lah. This one is explainable reason for cardiac defect. When patient got certain cardiac diagnosis, then you look for it and you find out lah patient has certain syndrome lah. But if patient not dysmorphic, then it's the random 3% chances for normal population to get any defect, congenital defect lah. It's 3% for anyone congenital defect lah, including the heart. Okay, mean unexplainable lah, it just happened by chance. Okay, so another thing, when you report your examination finding in pediatric, you must include the weight and height lah. So if the data for weight and height is not provided, then you have to mention lah your estimation. Patient build is appropriate for age, patient thin for age, patient overweight for age. So it's just by subjective assessment lah. And the patient height also, patient look long, short, or tall, short, or appropriate for age lah. Okay. So kalau negative bubble study mean the bubble will stay on the right side only lah, don't go to the left side. It goes to the left side means there is connection at 2 level lah, as either in the heart itself or in the lung. But most of the bubble studies our patient is liver transplant patient lah. So liver transplant will have pulmonary AVM lah, through ventricular venous malformation lah. This is because something related to the liver, so there is producing a lot of chemicals causing angiogenesis, causing connection between your at the capillary level lah, so it can cause AVM lah. By right, your capillary will filter the big molecules lah, including your bubbles. So if there is connections, no need to filter, everything can pass to the left side. Another reason they go to the left side is PFO lah, but this patient don't have PFO. This one pun, all the liver patient all positive one lah.
So the AVM is congenital?
No, it's pulmonary AVM, acquired because of the liver disease lah. It can be congenital also lah. If memang tak ada liver disease, then suddenly got bubbles suddenly positive, or something they suspect the lung got something problem, then they work out for echo, do the bubble test, then something positive, then could be something congenital lah. This is a bit too much for your level lah. Complex cyanotic heart disease, situs inversus, dextrocardium, BORV, TGA, BS, BST, dapat gland dengan AV valve repair, dan fontan. Okay lah, so many things lah. So basically it's a single ventricle kind of thing lah. Kalau you nampak ada gland, ada fontan ni, think of single ventricle. Kalau tak single ventricle, tak buat fontan, tak buat gland. Why did I stop you about single ventricle? Remember or not?
Directly connect the venous power.
So the main thing is we don't kacau the heart. The operation will be
By
outside, extracardiac.
we bypass the heart to the
Means
venous.
the connection is become plumbers lah. We connect here, connect there, connect here, connect there. So basically to relieve the pressure, all the return venous blood straight away go to the lung. From SVC, IVC straight away goes to the lung. Alright. Then the heart only receive back the blood from the lung, then pump to the body. Okay. But the SVC, IVC straight away goes to the lung. That's what gland and fontan means lah. You direct your punya SVC go to pulmonary artery, then you direct your punya IVC to the pulmonary artery. SVC, pulmonary artery easier sebab next to each other. But SVC cannot potong and tarik. You kena letak something lah, conduit. Because jauh kan, bawah ke atas ni jauh. So you kena put conduit, which is your fontan conduit lah. Put there, then connect to the pulmonary artery. That's why they makan ubat. That's why they are on warfarin, they are on aspirin, depends on how difficult the surgery lah. More difficult the surgery, the higher the anticoagulant lah. But some not very difficult, they are on aspirin only. Okay, but most of them on warfarin. Okay, this patient on warfarin or not? Got an R there.
No, INR target is less than 2.
This one should be 2 lah.
2 and
Or some 1.5 lah. This one 2 to 3. Some will target. The target is set by surgeon one because the surgeon knows how difficult, which one is more likely to thrombose and all that lah. Okay. I think that's all you need to know about single ventricle. Okay. And sometimes we send this blood also lah, RP, LFT, ABC once a year lah. You have to see. Liver, why? Because you fontan, you tarik the IVC to pulmonary artery kan, so you kacau the IVC is near the liver kan, so can cause fontan punya liver ni lah, liver problem, liver related problem lah. So far liver function is okay. You hantar HB, HBC, patient yang single ventricle dia akan cyanotic lah, right? So you want to know lah HB dia okay ke tak. Cyanotic patient will use up your iron more. Why? Why cyanotic patient will use your iron more? So it's a compensatory mechanism lah. So you don't have if you don't have enough iron reserve, then you become iron deficiency lah. So that's why make sure HB is okay. And see the MCV, MCH probably low. So probably iron reserve tak cukup juga. Sometimes we start jugalah some iron supplement sekali. But this one post fontan already the saturation should be normal one. So probably they won't use as much already lah. Okay. So the good thing about this thing, when they started before gland, they are like 70s, 80s. When they start going for BT shunt, then saturation will be better. Okay, some do BT shunt first lah. When they do gland at 1 year, 2 years, they have better saturation. Then fontan is even better lah. So why need this 3-stage punya operation or 2-stage punya operation? Depends on the saturation level. The main thing because you punya oxygen requirement will increase when you get bigger. So you need more oxygen, you need more blood flow to the lung. So that's why the first two punya connection tu not enough. You still need the IVC, the last supply to the lung. Tengok clubbing grade. Usually I use this one lah, it's easier. Okay. And fulfill, maknanya loss of angle. Okay, so grade 2 beaking already. I think she's grade 2 lah. He only got beaking. Dia tak ada ni lagi. Grade 3. Increase pop. Then grade 2, grade 4 pada atas nampak macam drumstick already lah. Okay. She's probably somewhere grade 2, grade 3 lah. Definitely there is beaking still there. The pop tu I don't think yet. Because you can see the beaking sekali. So you all don't know the calibration term. So when you read ECG, always see the first part other than see the patient's name, patient RN when you do the ECG. First thing before you baca the P wave semua tu, see the calibration first. But the one the nurse also cerdik, they put half. Put half, then you know lah it's half calibrated to smaller degree lah. Because sometimes the ECG is just occupying 12 boxes sampai di other lead. So dia, kalau you continue, you kan tak nampak apa-apa, you tak ada nak baca. So dia akan make it smaller. So whatever 3 boxes tu is always times 2 lah. Besar kan. Tak perasan the PVC is there? Yes, PVC. This one is just PVC lah. If you see 2 PVC, okay, one PVC, QRS, another PVC is called bigemini. Okay, kalau every 3 bit is trigemini. Maknanya 2 QRS, then suddenly the third one is trigemini lah. Is coupling macam tu lah. Kalau 1 QRS is bigemini. Okay, I show you the is the cardiac fellow punya CME hari tu.
Tapi the underlying coordination.
Like sometimes normal. So ventricle like inside ada congenital heart lah, but never mind. Just want to show you the echo. What rhythm is this? Yeah lah, MVF ataupun aberrant SVT lah. Aberrant SVT means SVT with what? QRS complex. That's all. Okay. But if put VF, we wouldn't fault you lah. Okay. You see what complex QRS? Then okay.
I thought she come to follow up because of the
Syncope.
the syncope.
For this one, see the holter for her, this patient is 4%. For her is 11% ventricular rate. Anything more than 10% is significant lah. Sometimes we want to start propranolol lah, but she's remain asymptomatic, so we don't start lah. But
She said 2 weeks got started.
no, but it's just palpitation lah. But nothing like macam causing, nothing significant as compared to syncope lah. If like recurrent syncope, very symptomatic lah. Just palpitation, could be just something watch and see first lah. Let's go. So anything you find? Got murmur nak? No murmur. So got long slender finger nak?
Long standard finger that the risk sign
Positive.
is positive, but the thumb sign is negative.
Okay, any high arch palate?
High arch palate.
Any overcrowding thing?
Overcrowding.
The thing looks normal to me though.
Maybe,
There's the overcrowd, there's like
it's
overlap.
Not very alignment.
It's overlap with each other lah, overcrowd tu. So got high arch palate lah.
No better skeletal, no
Got sclerosis nak?
scoliosis.
Didn't examine.
Sclerosis
That's the easiest one to find, you know.
need to write down.
Looks sclerotic to me lah. Got one of the bit humpy also one side, something like that. But if you open up, probably got sclerosis. Here got sclerosis. So got some learning disabilities. So the eyes, she's not wearing spec. The eyes kan ada apa? For Marfan.
Oh, Marfan.
Ah.
Eyes.
Lens subluxation.
Oh,
Okay, that's one. But more common is myopia lah. And very high power myopia.
the eyeball.
Yeah, something like that. Because the lens detachment cause the connective tissue problem, right? Okay. Those two are the most common thing lah for the eye. Facial features, then to look carefully. You have to find out what is under the some malah hypoplasia kind of thing. Eyes a bit sunken kind of thing. So they look carefully lah. Okay, for musculoskeletal as we said just now, like this as well. And then the height, standing weight ratio around 0.085. The arm span to height ratio more than 1.05 lah. The arm span ratio to your height.
0.85 is what?
0.85 the standing height and sitting height ratio. On top of it got scoliosis. Lung also there is issue with spontaneous pneumothorax. Okay. Another spine issue is your dural ectasia lah. So dura got some ectatic, some small dilated or small, I can't remember, but the symptom either back pain or maybe some urinary incontinence kind of thing lah. I can't remember. You can say baca lah. But most of the time the more significant one is always the heart lah, which is your aortic root, okay? Then macam bapor lah. Okay.
After the hypermobility of the joint, how to explain?
Hypermobility
Of the joint.
of the joint, you know,
Because it's found in my sleep.
you know the thumb sign
The
ke?
thumb sign.
The thumb and the index finger, they can do this right?
There's something you can reach.
That one they can do this something. Okay. The Batten sign, Batten score or something lah. You can do the Batten score. You Google Batten, then they will show you what score. One of it is that you can do this thing as well. See, can go lah.
Okay,
Nah,
the pulmonary hypertension, how to diagnose the pulmonary hypertension?
how to diagnose pulmonary hypertension at umur berapa? At what age?
What age?
Big children, babies.
Babies?
Babies. Usually they are oxygen dependent. Most of the baby kalau pulmonary hypertension from the birth, the oxygen requirement will be very high lah. Okay, that's why they taking in as usual, and then when you do the oxygen SpO2 hypoxia lah, saturation tak bagus, and then there is very lebar saturation lah, easily disturbed, you disturb, easily disturbed. But those yang cyanotic, they will cyanotic all the time. Memang saturation dia maintain 80. This one kejap okay, kejap tak okay. It depends on how bad is the pulmonary hypertension lah. So if you want to diagnose PPHN, you need pre and post ductal saturation. Right, properly. And the rest is post ductal lah. This one is only pre. The rest all post ductal. Okay. So ada discrepancy about 5 or more than 5 is diagnosis of PPHN lah. But if patient very hypoxic, the pre and post about the same lah selalunya. Kalau level 80, 70s, buah baby 70, 80s lah. But when the high saturation, no normal, the rest, the PPHN will have discrepancy lah. Okay. Then on X-ray, can be cardiomegaly. On echo, you can see the dilated right-sided, high tricuspid regurg, cause of pressure very high. And then the shunting at the PDA or PFO level will be right to left lah, because the right side pressure is higher than the left side. That's in babies lah. But most of these babies, when they recover from that infection, whatever it is, the TR probably will remain high. Over time, it gets better lah if the lung is better. But in pulmonary hypertension because of lung issue, like BPD, bronchopulmonary dysplasia, or chronic lung disease in premature, those are one of the risk factor to develop pulmonary hypertension lah. And then another risk factor in bigger children, any lung problem as well lah, like chronic suppurative lung disease, patient with cystic fibrosis, underlying PIBO, post-infectious bronchitis obliterans, all those lung problem lah. Those causing pressure in the pulmonary artery very high lah, so causing pulmonary hypertension. Okay, that's another causes. Then Down syndrome can have primary pulmonary hypertension, mean that they are born with high pressure from the beginning lah. But in the end, initially you will try to rule out other causes first. But somehow when the infection settle, can offer oxygen, but somehow we do the echo, still the pressure still high lah, the PR still there. But somehow they not. They may be dependent on oxygen, maybe dependent on not on oxygen lah. But those are primary. There's also primary hypertension in bigger children as well. Not dysmorphic. I think not syndromic, but they have primary hypertension lah. I mean there's no unknown cause lah. Primary or slash idiopathic lah. No lung problem, but somehow primary hypertension is still high. Okay. Another group is the isomango group lah. Those with congenital heart disease will have primary hypertension as well. Those are 4 different categories of pulmonary hypertension lah. So to diagnose hypertension, you need to basically look for what are the risk factors first as well. Okay, then you look hard for it lah. Examination finding, you will hear the loud P2 murmur, and the loud P2, the S2 at the pulmonary area will be loud. That's what P2 means lah, loud P2. Okay, they will have the R murmur as well, which is pensaturate murmur dekat left lower CMH lah. Okay, and the behavior also lah, easily disturbed when disturbed, when crying, when you poke them, easily disturbed. Okay, when you suction. Okay lah, those are the some of the features lah. Okay, and they are predisposed to right-sided heart failure lah. Yeah, lepas tu mainly will be freeze on the right side. Then you have maybe edema or ascites as well lah. But those are late stage lah. Most of the time, right, heart failure is hepatomegaly lah. some pulsating liver as well. Those kind of features. Okay, understand? Can follow? Okay. So treatment for hypertension treatment. That's one of the treatment lah, but the treatment depends on the causes lah. The lung problem, you have to treat the lung properly lah. Rehab the lung properly, treat infection vigorously, prevent infection by giving immunization, extra vaccination like pneumococcal, synergies for the palivizumab for RSV. Okay, then you do pulmonary rehab very often. You do antibiotic tuning in cystic fibrosis. Then
antibiotic tuning at the bawah is not actually they tune for antibiotic.
Money they just start antibiotic lah once a year just to kill off all the colonies somewhere in that. Then you ask recipe lah, I'm not sure. Okay, and then you make sure patient supported well on NIV, do the suction frequently to prevent the progression of the lung problem lah. Lung very bad, pulmonary hypertension won't improve. Okay, kalau no primary causes, then you straight away give the medication lah, like sildenafil. Okay lah, then the other group as well lah. Sildenafil got, tadalafil got, vardenafil got, so many lah, those group lah. And then the second group, the ERA lah, the endothelin receptor antagonist, macitentan, bosentan. Then there's another group as well. Okay, alright.
After the VSD, how large is considered large?
VSD more than VSD kalau more than 50% of aorta,
50% of the aorta.
Another thing is symptom of heart failure, large lung, or dilated also lah from the chest X-ray, from the echo. Imbalance chambers, anything causing volume overload consider large, moderate or large lah. Kalau ada failure symptoms, it's large already.
So the SPE prophylaxis is just antibiotic before any dental procedure?
Not just dental or any surgery,
procedure.
any invasive.
Is there any explanation for the dental and the effective endocarditis or how the bacteria show?
Because all the common bacteria causing infective endocarditis come from the oral. That's how they correlate it. The sanguinis, parasanguinis, stap, all these things come from the oral punya normal flora. So dental hygiene is very have to be lah. The only congenital heart disease that don't need SBE prophylaxis is SD lah, small SDs. No need SBE lah. But the rest of significant shunt, significant regurg, need SD lah. PDA also, even PDA, PS, everything. Turbulence flow, there is some stagnant risk factors. Okay, alright.
Ask about dengue. After you say the dengue causing the hemorrhage is because the inflammation of the vessels.
No, because of prolonged shock.
Prolonged shock.
Yeah.
Because I searched online, is that increased vascular permeability. So
Okay. No, but the increased vascular permeability is just another risk factors for the bleeding. When you have increased vascular permeability, you lost your clotting factors and all that lah. So predisposed patient to bleed. But this kind of bleed, it will be small bleed. But the one in dengue causing significant bleed is because it's due to the prolonged shock. When you have prolonged shock, your perfusion tak bagus to the organ, then the organ will go into hypoxia and then you go into lactic acidosis lah. All these things will cause a lot of changes to the vessel as well. A lot of damage, can cause coagulopathy, can cause and then on top of it, patient ada thrombocytopenia and then also ada vascular permeability lah. All these things, the shock will cause of the bleed lah in the very high risk group, especially dengue lah. So it's always the shock is the cause of bleed. It's not really thrombocytopenia, not really the vascular permeability. A lot of dengue will have leaking, will have leakage. But why they do not bleed? Because they don't have shock. So when they go into shock, you don't correct it, you leave it for so long, they will go into bleeding lah. There are pathophysiology lah how does it cause bleed. Not just in dengue lah, anyone in prolonged shock, for example it is pun hypovolemic shock, cardiogenic shock. Then later on, towards the end pun they will go into the IVC lah, true or not? So in dengue, the IVC plus all this vascular permeability, thrombocytopenia, it just get worse lah. Understand? Okay. So the key point that I want to understand and people want the MOs to understand is don't let patient be in shock. That's the most important thing. You have to resuscitate properly. You have to make sure the fluids is given enough. If you're not giving enough, then we let patient into shock. That's the thing lah. So sign of early shock is could be abdominal pain. So abdominal pain, hypoperfusion. That's the main thing lah, takut. But abdominal pain in dengue can be a lot of things. Can be gastritis sebab tak makan, or dehydration. Can be hepatitis sebab capsular crash because of hepatomegaly, hyperemia, causing hepatitis lah. Then capsular crash can got pain as well. Then can be bleeding. The occult bleed most of the time happen at the gut area lah and the lung area lah. Those two lah most of the time. Sebab situ a lot of capillaries. That's why, right? One thing. And then you got abdominal pain as well. Then the pain cause is a hypoxia lah due to hypoperfusion lah. So that one hypoperfusion first, later on baru bleed. Okay. So patient datang abdominal pain, you have to be worried lah. Is it because of this, or those four? Which one it is?
Hepatitis, hypoxia, and always
hypoperfusion, causing hypoxia and bleeding lah.
bleeding.
Okay. You see, or patient yang septic shock, everything, when they go into the IVC, they bleed lah. Same also, right? Because everyone thought dengue bleed because of thrombocytopenia. The previous is transfuse platelet. No, now we're moving it just transfuse. Make sure patient perfuse enough. So make sure the lactate is well controlled, tak naik. Mainly you are giving enough oxygen, the blood flow to the organ lah. Kalau lactate tinggi, something not right lah. So I think important thing to monitor is hematocrit, blood test lah. Make sure the lactate is not high. If you lactate high, you know lah, some organs not perfuse very well.